And again, if you are here for this webinar focusing on anal pleasure and health, you are in the right place. Thanks for being here. We have two really fantastic speakers. We have Sammy from Hoimas in Kenya. Sammy is also an AVAC fellow, and he is going to be kicking us off with the work he is doing around anal health in Kenya. And then Brian with Albert Einstein College of Medicine is going to be walking us through a really fantastic workshop, diving into all the various things you can imagine and then some. So I am going to go ahead and stop sharing my screen now. And I am going to invite Sammy to join us at the proverbial podium. Sammy, you should be able to share your slides and go ahead and introduce yourself and walk us through your slides, please. And Sammy, I see you in the room. I'm not sure if you're able to come off mute. There you go.
Hello.
Hi, Sammy, we can hear you.
Yes. I'm trying just to share my slide. Let me just share and then give an introduction.
Sounds good. Thank you so much. And we can see your slides. They look good. Go ahead, Sammy. Thank you.
Thank you so much for everyone who has created time to join for these wonderful sessions. So my name is Gori Gosam Anyola from Hoimas, Kenya. Hoimas Kenya is a key population lead organization serving the key population typologies here in Kenya. So I'm also the current EVAC fellow for Kenya. So that is for 2024, 2025. And at Hoimas, before I got the fellowship, I was leading the clinical arm at Hoimas, Kenya. So today we are going to speak about something that is unspeakable. We know for the longest time the issues around anal health and pleasure. There are issues that have been often neglected within our programming. So this conversation is very essential, not only for individual health outcomes, but also for advancing HIV prevention, care and treatment for typologies or individuals engaging in anal sex. So the background will explore the epidemiology of HPV and its impact on anal health. We'll also look at the Hoimas AVAC advocacy overview, just looking at the objectives and progress of this advocacy initiative. We'll also briefly look at the clinical work at Hoimas, the specific interventions and strategies on addressing anal health. And we'll also lastly look at the progress and lessons learned, that is the insights from our journey so far when it comes to anal health and pleasure. So I'll briefly introduce my AVAC Advocacy Fellowship project, this project focuses on advocating for comprehensive and responsive health policies that caters for the needs and health services gaps for the gay, bisexual, and other men who have sex with men in Kenya and other key population engaging in anal sex. So in the advocacy project for Hoimas AVAC, I have three objectives. So the first objective is the integration of anal healthcare into our healthcare guidelines, specifically the healthcare guidelines for HIV prevention, care, and treatment. And this is not just anal health, but also including HPV screening, vaccination, and treatments into the existing updated guideline frameworks. So the second objective is to capacity enhancements and also stigma eradications, just to advocate for capacity enhancement for the healthcare workers, so just so that they can be able to provide stigma-free anal healthcare services, and also to increase awareness within our community so that our community members can access anal healthcare services without feeling stigmatized, and also access these services at a timely level or a early level. So the third objective is to advocate for the donor-funded programs, like to have annual health care as one of their minimum package of care within their HIV prevention care and treatment programs. Because for the longest time, the HIV prevention care and treatment programs, especially for the men who are having sex with men who are having sex with men or other typologies engaging in anal sex, their sexual health have been assumed to be met in these programs, yet they do not have a specific projects that target their sexual health. So why is this matters? Currently, the gap in the current practice is that the annual healthcare has often been overlooked, and with the narrow focus on HIV and STI prevention. So discussions around annual health always stigmatize, leaving individuals to rely on myth and trial and error. And from our community perspective, what we have been seeing as a result of this, we have been having people presenting to the clinic at advanced level, or what we call late presentation, because of the stigma that is there. They cannot access these annual healthcare services on a timely level. So addressing these gaps is very critical, especially in providing comprehensive and what we call person-centered care, a care that is centered on the individual health needs. And it's very critical for us to recognize that key population also have other health issues away from HIV itself alone. So I'll briefly provide you the background on HPV. We did a scientific study here in Kenya, Nairobi. And the reason why we did this, because we were having a lot of prevalence for the annual human papilloma virus for men engaging in GBMSMs, gay, bisexual, and other men who are having sex with men. So HPV is a human papilloma virus which causes a variety of conditions, including anal and genital warts. It can also cause cancers affecting the anal area, genital and throat, as you can see from the image. And from what we had learned from our community programming, so the severity and recurrence of these conditions, most of the time are always influenced by someone's HIV status. So what we are seeing, GBMSMs living with HIV were more vulnerable to severe HPV-related diseases. And also another factor that we noticed was ARV at their end. So consistence to antiretroviral therapy reduces the disease progression, because for the advanced conditions were mostly since for those people who are not adhering well, or they are now engaging back to treatment. So this is the HPV study finding that we did in Nairobi. So we had a population of 115 GMMSMs in Nairobi. So during the study, what we are doing, we are collecting annual swabs just to analyze the HPV DNA testing. We are also doing what we call HPV genotyping, just to analyze what we call the high risk and also the lower risk HPV genotypes, because we know for HPV we have more than 150 so far recognized HPV genotypes, and we are having the lower risk and also the higher risk genotypes. So the higher risk genotypes are the ones that are highly associated when it comes to malignant or cancer cases, and for the lower risk variances are the one that normally causes conditions like anal warts, genital warts, and these are genotypes like 6 or 11. So during the study, we tested the participants for the HIV status, just to understand the correlation between HIV status and the HPV infections. So some of the key findings were 51% of the participants had annual HPV infections. And out of the 51%, 84% were persons living with HIV, compared to 24% in HIV negative participants. So the high risk HPV genotype, so some of the most common high risk HPV genotype that were found included HPV 16, 35, 45, and 58. And you know, these most of the time are linked to cases of anal cancer and other forms of cancer. And also multiple high risk HPV infection were common among HIV positive individuals. So something interesting, and that's why we are having this advocacy in partnership between HOIMAS and HAVAC. 61% of the detectable genotypes could have been preventable by the current vaccine that is available in the country. But the problem is the vaccine is only accessible and readily available for HYW, adolescents, girls, and young women, especially within the mainstream healthcare system. So these are some of the conditions because of the stigma and lack of normalization of conversation around anal health. So most of our community members were presenting to the clinic with advanced level of conditions. And as an organization, we wanted to understand what could be the reason why it make people, our community members are receiving or seeking care at a late presentation, not at time level. So we really wanted to understand what are some of the reasons that are making people present with advanced anorectal conditions or anal diseases, including HPV-related symptoms such as anal warts. So most of the time they normally they normally run from the anal area to the genital area to the groin area, especially for the advanced ones. So we set up a program that is called WEMA, that is Wellness for Men's and Genital Health. And one of the things that we are doing, we did what we call creative space sessions. So these were peer-led discussions with community members just to understand their anal health-seeking behavior, knowledge barriers, and also their perspective when it comes to anal health. So another thing that we did during when we were having this conversation, there's something that came out. These are conversations that we did with the community members across Kenya in different counties. So one of the things that was coming out, the community members, they were telling us they are sort of tired with what we call the usual education, because the current education within the HIV prevention programming for key population engaging in anal sex, it has focus so heavily on things to do with HIV prevention. That is, do you know your status? When last did you test it? Are you on PrEP? Are you using condom? But they said they wanted to be identified and oriented to something that it's person-centered, a program that meets their specific health needs away from HIV disease itself. They also want to be oriented to other more scientific ways of prevention and also pleasure. So another thing that we did, we promoted the annual healthcare seeking behavior, whereby we normalized this conversation around annual healthcare, and we launched a WEMA website. The WEMA is Wellness for Men's and Genital Health. And for this website, what we are doing, we are creating awareness, education, and also trying to enhance referrals. Because one of the things that we noticed, most members who are coming at advanced level will start to ask, like, what could be the reason why you didn't seek care at a timely level. Most of them were saying that they were not aware of what was happening to them. So there was need for us, or they were not aware where to get stigma-free anal healthcare services within Kenya. So that's why we decided now to promote the anal health. So another thing that we did, we revamped the anal health. So we revamped the annual health treatment program. So we standardize for most of our clients who are visiting, annual health care was one of the minimum package of care. The way we have integrated other services within our HIV prevention care treatment, like the way we have integrated mental health, ACI, that is how we have also integrated conversations for annual health care. So clients who are coming to our facility, annual healthcare is part of the information and package that we are giving, and also for those who are due for screening, we are screening them for the annual healthcare. So we standardize also the follow-up, regular reviews until full recovery, because one of the things with anorectal conditions, these are not conditions that cannot be treated with a one-off things. You need to do a follow-up with the clients just to make sure that their symptoms have remitted so fully. So surgical referral and recovery program. So we didn't have a program that specifically support those advanced anorectal conditions, that because most of them were not responding so well to the conservative management. That is the treatment with podophyllin ointment and also other treatments. So the only option that there was responding well to that, and also as according to the current guideline for annual health, annual STI management in Kenya, for those advanced level annual warts need surgical excisions. So we established partnership with a community-friendly private health facility, whereby We were taking those clients were coming across the country with advanced anorectal condition for surgical excisions. We also created what we call a recovery center for post-operative care, just to ensure that the clients who have undergone surgical excision have not developed complications, because most of them were coming our distance far away from Nairobi, so it could not be possible for us to have done that minor procedure, then also discharge them. So another thing that we did is we did what we call capacity assessment. We evaluated the GBMSM-led clinics just to identify what are some of the capacity gaps in their clinics to deliver stigma-free anal healthcare, and also trying to see what are some of the potential opportunities for scaling the best model at OIMAS to this other key population-led organization, because it wasn't sustainable to keep referring people those long distance. You can imagine someone having that obstructive masses sitting on a matatu on a car for more than 8 hours. So another thing is published journals, research papers, case studies, and opinion pieces, just to raise awareness. And some of these, there's one that was released recently, and it was shared by Jim in the Choice Agenda. It was just trying to capture the what we call the patient journey, and also the case study, like tracking the patient journey from the first time they started noticing that they're having a symptom that is not usual to them, the engagement with various healthcare facility, with healthcare providers, until to the last stage for their symptoms resolutions. And this is just part of advocacy, and also trying to do opinion cases. As someone who has worked with key populations, specifically an MSM-led organization for the last 5 years, I've experienced these first-hand experiences when it comes to anal healthcare and also HPV-related conditions or complications. So some of the progress that we have done in terms of the advocacy with AVA, so, and also the WEMA. The WEMA study we did with support from with the University of Manitoba, which is based in Canada. So what we did, because we are getting a lot of referrals and most clients were coming at advanced level. So one of the things that we decided to do, we really wanted to understand what are some of these challenges that are making these other healthcare providers who are working in this key population-led organization keep referring clients, including the condition that could be treated so easily at their end. So we did a 2-day workshop, and we brought together all the clinicians, healthcare workers, clinicians, nurses, counselors who are working in key population-led organization, just to understand their knowledge and some of the challenges that they are facing when it comes to providing stigma-free anal healthcare services. And one of the main things that came out was recommendation for us to develop what we call the anal healthcare SOPs, SOPs for anal healthcare screening and also for genital health screening, and also an expanded HPV index screening sheet that can also take into account for other anorectal conditions or diseases. So from that meeting, that was the recommendation. So we now moved to now the second stage, whereby we did a collaborative workshop, whereby we brought the NASCOP, the NCDC, representative from NASCOP and NCDC. They are the bodies in Kenya that are heavily mandated to do activities around HIV prevention, care, and treatment, and also community leaders from key population-led organizations, just to co-create the WEMA study addressing the GBMSM health needs. From there, we moved and had a meeting with the Nairobi County Health Management team, because here in Kenya, health is a devolved function. So, and since the study was being done in Nairobi, there was need for us to meet with the Nairobi Health Management team. So we had a meeting with them, and we are just introducing to them the study, the WEMA study to them. And part for that, another thing was also to see how we can also, where the HPV vaccine can be accessible to our community members. So the second, it was community engagement. So we did what we call the creative space session, just to understand barriers and facilitators to anal health. These were just informal discussions with community members, just to understand what are some of their barriers, what are some of the drivers when it comes to the uptake of anal healthcare services. And from these creative sessions, we one of the things that came out one of the things that came out clear, it was the knowledge, the understanding for the annual health, the knowledge towards around annual health, and also the annual pleasure. There was a lot of myth, controversy to factuals. So development and review of the tools. So we collaboratively developed the SOPs for annual health and also expanded HPV screening tools, which I led the process together with representative from NASCOP and also one representative from WHO, Dr. Sushena. So after I was leading the process, so after the first draft, we met with the healthcare workers whom we were with together in the initial workshop, just to review and also just to make sure that we are developing a tool that is very diverse, capturing perspectives of everyone. We also had a review with the Nairobi County Health Management team. From there now, another thing that we did is the capacity assessment. I had talked about it, that was part of advocacy, seeing how we can scale up the best annual healthcare model being implemented at Hoimas to this other GBMSM, so key population-led organization. So with the AVAC advocacy fellowships, I've been able to engage myself in various national technical working groups, presenting the need for us to integrate annual healthcare and HPV into our HIV prevention care and treatment guideline, because the lack of these care packages within our healthcare guidelines, it's something that creates an environment where stigma, discrimination is highly perpetuated. So there's need for us to have annual healthcare as one of the minimum package of care for key population individuals engaging in annual sex within the HIV prevention care and treatment programs. So another one, it was donor engagement. So recently we had a high-level meeting with the PEPFAR country coordinator, and one of the things I presented some of the key asks, especially when it comes to the sexual health needs for individuals engaging in anal sex, and the PEPFAR COP planning process continuously. So he promised to have future consultative and also the future engagements for this process. Lastly is publications and advocacy. I've talked about the journals, patient journey, case studies, trying to highlight some of the challenges, some of the gaps, and also some of the best practices when it comes to management of these HPV-related complication and annual health conditions. So lastly, our experience with annual diseases and treatment, most of the time, these conditions, the common ones are annual warts, annual discharge, hemorrhoids, ulcers, and fissures. And because of the stigma, most of the time you could get the annual STIs has what we call delayed diagnosis. They are not being diagnosed early because most of the programs do not have specific screening tools that are tailored to screening annual STIs and other anorectal conditions. So one of the things that we have been seeing recently is our community members are now coming with what we call annual fistulas as a result of delayed diagnosis of annual infection or anorectal conditions. So often the presentation are always mixed, contaminated with fecal matter, perpetuating or increasing the risk of secondary infections. So another thing that we have noticed is HIV influences progression and recurrence of HPV-related symptoms. So clients often come to the clinic when the disease is already advanced and starting to interfere with their daily or everyday life, the way we had seen from the images that I had shown earlier. So why is this important? It serves as a key entry for HIV case identification and also re-engagement in treatment. That is one of the things that we learned from our programming in the control of HIV acquisition and transmission, and this is as per the WHO guidelines, which has recommended away from focusing on other factors that increases vulnerability for HIV. There's also need for us to also focus on anal health because of its high HIV acquisition and transmission rates. So early detection and treatment have significant impact on HIV prevention because of what we call the microabrasion and the microabrasion of the tears that increases the extent of infection. So I would like to acknowledge Hoimas Kenya, AVAC, the MSM HPV research team, University of Manitoba research team, and also the Partners for Health and Development Africa, PHDA. Thank you so much.
Thank you so much, Sammy, for really a wonderful presentation. Please, everyone, give him some love in the chat. And if you have follow-up questions or comments, please go ahead and put those in the chat and Sammy can address them directly there. So Samuel, if you'd like to stop sharing your screen, I'm going to invite our next presenter, Brian Kuttner, to the proverbial stage to take us through his slides. Go ahead, Brian, introduce yourself and get us going. Thank you so much.
Thanks, Jim. Thanks, Sam. Sammy, that was so incredibly important to hear about that work. And it's really cool because we're in different parts of the globe, but we're working on very similar things. So this is really nice and complimentary. You can see my slides, right, Jim?
Yes, they look
Yeah, great.
gorgeous.
Okay, great. Gorgeous, gorgeous, great. All right, so I'm going to walk you through three things today, and I'm going to try to breeze through this as much as possible to give you a kind of a quick overview so that we can get to time for questions and answers and respond to things that you want to hear about. So we're going to cover the science of this topic a little bit. Sammy's covered that quite a bit. I'm going to cover a little bit more, and then get to some answers to frequently asked questions that are typical ones that come up pretty often, and reserve some time, hopefully, at the end for more of yours that are specific to you to make it, as Sammy said, client-centered. And then also make sure that you leave with some resources. Before we get into this, I just have some guiding mantras. The first one is slow and steady with this topic. And this holds true not just for the actual act of anal play, but also for folks who are fairly new to the topic. We'll go slow and steady into this, ease you into the process. Also, ouch, that holds true for any kind of anal play too. Any sense of pain or discomfort is an indication to stop and try something different and increase pleasure rather than tolerate pain. And that holds true here too. If I ever say something that feels like, oh, that doesn't land so great, let us know in the chat so we can respond to that. And the last one is just to have fun, because this is a very fun topic. We should be enjoying the pleasure around the subject of anal play. I'm going to tell you a little bit of the background of how I got involved in this. I am someone who engages in anal sex myself, but I also used to work in a bathhouse doing HIV counseling and testing and STI screening in New York City. And frequently I would hear from men, cisgender men mostly in their 50s, who would say, oh, when I get fucked, I bleed. And that's normal, right? Almost as though they're asking me, is it normal? To Sammy's point that people are learning by trial and error and have a lot of myths around the topic of anal pleasure and health. But it also struck me that they were learning about how to test for HIV and STIs, but they were not learning basic information about anal health. That was missed. And that was combined with an experience around the same time of a friend of mine calling me, a cisgender woman calling me after she'd gone to the gynecologist and said to the gynecologist, there's a little something like just below, could you look at it? And there was a little anal wart. The gynecologist effectively kind of slapped her on the hand, not literally, but figuratively, and said, are you having anal sex? You shouldn't be having anal sex. Are you married? And really shamed my friend. And it really just occurred to me, you know what? The healthcare field needs some education about this, which is what you've seen Sammy doing at a phenomenal level. So for today, what I'm hoping you leave with is an understanding of the scientific rationale of why it's important to address this topic. Learn how to communicate with patients, hopefully with some responses that are sex positive, accurate, and destigmatizing. Because if our clients, as human beings, are experiencing myths around this topic and learning by trial and error, we might also be filled with some myths too, and let's correct those myths. And then gain access to resources. That's primarily with the website of resources that I'll offer to you. All right, I'm going to start with the background a little bit. What's stigma got to do with it? So I mentioned these experiences that I had in the bathhouse with my friend on the phone. This formed some research that I did. I interviewed 35 folks from around the country. I then created a measure of anal sex stigma because I was curious if that was even a thing to measure, if it had public health significance. And then I did some statistical testing in about 1,500 cisgender gay and bisexual men in the United States. So some limitations to this research, but here's what we found. The main message that we found was that folks who said that they endorsed high stigma toward anal sex, either internalizing shame about that, anticipating mistreatment in a healthcare setting, or just lacking information, those folks were less likely to engage in biomedical and behavioral HIV prevention. And that was a pretty pretty strong association. But the main thing that's really important here is that it's really high stigma leads to less comfort talking about anal sex with a healthcare provider. And then that leads to less engagement. And this is borne out by a quotation that one of our participants shared with us. This is someone who provides anal healthcare in the Midwest. And he said, I think patients know that the majority of healthcare providers don't want to deal with their bottoms. So many providers, they're going to send my patients for a rectal exam or to do a swab, an anal swab. It takes 30 seconds, but they don't want to do it. They don't want to go near it. And it creates a kind of baseline stigma there. Oh God, nobody wants to deal with my, you associate it with poop and smelling and farts, all of the above. And then you get a sense that your primary care provider or somebody else doesn't want to deal with it. It makes you feel like there's something wrong with that. And you can imagine how that would then contribute to someone's lessened comfort talking about anal sex and therefore less engagement in health services. This is the statistical model, which is just the same thing as what I showed you in the simplified model. But what I really want to highlight here is ignore all the numbers. Just look at this hot pink, which is about social support specific to anal sex. This is informational and emotional social support, someone I can go to talk about anal sex, someone who can help me with the emotions, the feelings I have about anal sex. That is associated with less stigma, more comfort talking with a healthcare provider about anal sexuality, and more engagement in HIV prevention. So to Sammy's point, if we are able to empower people with proper information and dispel some of those myths, it could be that that helps with engagement in HIV services, but also lessens stigma. And so I'm going to skip this slide because I think Sammy got to it quite a bit, why there's a reason why we should be doing this. But what we ended up doing is getting some funding from the federal government to study how to mitigate stigma toward anal sex. And we did that with a 2-day in-person workshop followed by some quality improvement services. But the basics we covered were about anal physiology during anal sex, which I'm going to share with you today, and also ways to communicate with clients that naturally lead toward HIV prevention. So that's our project that we were doing. And we piloted this in China before we did it in the United States. And here's something really interesting that an HIV clinician said in China. We always tell people how to protect themselves, but we don't know how to talk to people about pleasure or improving one's sex life. As far as I know, and this is before this workshop that we delivered in China, no one's done that. I understand that we are always able to tell people what they shouldn't do, and we're not able to tell people what to do. And so that is part of the goal here, is that we can actually instruct people on how to have anal play in a way that is pleasurable and healthy and less harmful. And if you have any questions about whether incorporating the topic of pleasure into sexual and reproductive health is even scientifically valid, there's a great systematic review that came out a couple of years ago to say that this is something actually that is indeed has a positive impact on HIV services. All right, okay. That was a quick down and dirty of the science. Sammy covered quite a bit too. So I'm just going to get into the frequently asked questions. These are the things people most want to know. And I'll highlight that we've got a website which has nearly everything that I'm going to cover today is on our website. So lest you worry that you're not going to get an answer to something, the answer is probably on this website, which I will walk you through at the end of my presentation. All right, we're going to talk about the prevalence of anal sex, how many people are having anal sex. And just to bring this home, look at these images. They are from all over the world. They're also over time and space. We've got ancient images. We've got even space-aged images. We've got Star Wars having anal sex as well. And so it means that people have been having anal sex for a very long time. That's what it suggests. If it was depicted thousands of years ago, it's not something that's new. Now, there's some issue with learning about this topic from the science, because in some areas we have a lot of data. If you look up HIV and anal sex in peer-reviewed literature, you're going to see a lot of data. That's the green bucket. And then we've got some data around recently, more stuff about douching and enemas. We've learned a little bit more about that recently. But then there's other areas that are just completely data-free, like the physiology during anal sex. We just don't have a lot of studies where someone's actually measured what's happening during anal sex, like they have, for example, during vaginal penile sex. So I'm covering some of the stuff. There's some stuff we know, some stuff we don't know. Just keep in mind that we don't know everything that there is to know. I want to point this out though, okay? This is something we do know. If you compare a color on the left to a color on the right, let's see what the take-home message is, okay? So this is men on the left and women on the right. It's very binary. I assume these are cisgender because this is before even the term cisgender came about or was used popularly. And what you see is that among men, about 5% of men have received anal sex in the past year in the age group of people who are 20 to 24 years old. And then 23% of women have received anal sex in the past year. Okay, so put your thinking cap on. What does this suggest to you? Far more women than men have received anal sex in the past year. So even though sometimes one of the myths that people believe is that, oh, this is a thing that gay and bisexual men do, and it's a health concern for them, it's actually a health concern for women too. And I would argue it's really a health concern for anyone who's got an anus who could possibly be using it for pleasure. And this is an older study with some kind of outdated terms, but just suggests that by absolute numbers, there are more heterosexuals who've had anal intercourse than there are homosexuals. And in fact, there are about 4 to 7 times more women than men who've had anal sex in their lives. It's not telling us the number of times they've had it, but just that they have had it, which suggests that it is something we should talk about with all of our clients. It's also important to note that prevalence depends on how you ask people the question. So this is a study that was compiling prevalence across the globe. And I'm just going to look here among married men in Benin in Africa. And they compared people who were asked in a polling booth survey, which is anonymous, and then face-to-face interviews, which is not anonymous because you can see someone's face. And the prevalence is about 5 times higher. If you have a face-to-face interview, about 3.5% of men said that they had anal sex. If it's in a polling booth and it's anonymous, it's about 5 times higher than that. So you can see that there's something there that's influencing whether people tell what's really going on. So here's what we know. Surveys tend to ask mostly about vaginal penile intercourse. There's very little reliable data for lesbians or women who have sex with women or trans and non-binary people. There's really only one study that I could find among lesbians from 2000, the year 2000. There's excellent reviews and meta-analyses about HIV risk. As Sammy pointed out, that is kind of the bulk of what people learn when it comes to anal pleasure and health, or really about anal health, even though that's not what people want to learn. They want something more than just talking about HIV and STIs. We're missing a lot of reliable samples from most parts of the world. We don't really know how often people are having it. And also, there's really no meta-analysis of global prevalence or other forms of anal sex that aren't about anal intercourse. Now, why is that? Part of that is because there's a taboo about this subject. And a taboo is really just a prohibition. It's saying, don't do this. But we often don't know why people say don't do it. Eating meats of cats and dogs, for example, that's a taboo. We don't know exactly where it came from, but it feels like, we shouldn't be doing that for sure. And you can see it borne out in some of the science too, because only recently has the focus turned to anal sex and heterosexual HIV transmission. Before, the topic was, this is just about gay and bisexual men. But actually, there's increasing data that's suggesting that some part of HIV transmission among heterosexual people is attributed to anal sex. And then only recently was a condom even approved for anal intercourse. I don't know if you all knew that, but it's not something that was approved until recently. So it's pointing out that there's stigma kind of throughout the system. And what I'm going to do now is I'm going to give you an overview of anal sex physiology, because one consequence of that stigma is that we lack some basic information about how people can have anal sex in a pleasurable and healthy way. So I'm going to go through the structures. I'm going to talk about musculature as well, sources of pleasure, lubricants, and then concerns that people have about poop. I'm going to try to breeze through this because I want to make sure we have time for Q&A, but here's a little physiology. So we've got this person over here. We can see is there transverse colon, descending colon, and then sigmoid colon, and then a rectum. And we're going to focus on this little area over here. So you can kind of see how it goes. Here's the sigmoid colon, here's the rectum, and then here's what we're going to call what is the anal canal, and then the anus, which is the anal opening, or commonly referred to as the asshole. So the colon is about 6.5 feet long, and the sigmoid colon is where it ends. It's an S-shaped end of the colon, and then it leads into the rectum. It's really important to keep in mind that this is this S-shaped colon, because people tend to think that poop just sort of goes along this little thing, right, and then just sort of lands over in the rectum. But actually, it sits over here before it enters the rectum. So the rectum is generally free from fecal matter or poop. Generally is free of that if you got enough fiber in your diet. Generally. Here's the sigmoid colon again, here's the rectum, and then here's the anus. And let's talk about the rectum a little bit. It's about 5 to 9 inches long. What else is about 5 to 9 inches long, you might ask? And a certain appendage that can go inside of the rectum? Yes, indeed. You got it. Bingo, you win. A penis is also about 5 to 9 inches long on average. It's also 1.5 inches wide, and it stretches quite a bit. In fact, under general anesthesia, someone's rectum can expand so much that someone can fit a fist in there very easily. And with proper relaxation, a fist can be placed inside the rectum as well. So it doesn't have to be a penis. It can be a finger, it can be a fist, it can be an object as well. It fills with poop and gas right before release. So as food is digested, it produces gas and fecal matter, poop, feces. That kind of sits over here in the sigmoid colon. And then once it exits the sigmoid colon, it enters the rectum. And then that's when we generally get this feeling of, oh, I got something in there. I feel something. I feel a sense of fullness. It's either gas or it's poop. And that's your signal, okay, I'm ready to release something. This is going to be really important when we talk a little bit later about having anal sex. So it's generally empty most of the time. Let's talk about the anal canal. It's right there, just the last 2 inches or so. It's the first few inches beyond the anal opening of the anus. And there are 2 rings of muscles called sphincters. And they close and open the anal canal. You have another sphincter. You've got several sphincters throughout your body, but you've got a sphincter in your mouth too. This is a ring of muscle. These lips, a ring of muscle. So it's similar at the other end of the body. You don't have as much control over your anal sphincters as you do your oral sphincter of your mouth. But here's an image of the 2 rings of muscle. Here's the anal canal. Here's the internal sphincter, which is this ring of muscle, circles around, and then the external sphincter is here. And then here is the asshole. This is the anal opening. So this is someone's scrotum. Here are their legs, their thighs, and then here's a little butthole right there. The anus is densely packed with nerves, and it's very sensitive to touch. I mentioned how the rectum, you get a sense of fullness in the rectum. That's how you know that there's something in there. Over here on this part of the body, I'd like you to do something for me, actually. I'd like you to take your hand, hold it up like that. Thank you, Samantha. I can see you doing it. I love the participation. And also, Carla, thank you. And what I want you to do is just take your other finger, index finger, and just rub the palm like that. Notice what it feels like. And then turn it over and then touch the top of your hand. And what do you notice? I guarantee for almost all of us, there's more sensitivity here in the palm. That's because it's more densely packed with nerve endings. And that is very similar to the anus. It's very, very densely packed with nerve endings. That doesn't necessarily mean that it's going to be pleasurable, but it has the potential to be pleasurable. In the same way that just someone touching the palm of your hand doesn't necessarily mean that you're going to experience pleasure, but someone else doing it or you doing it to yourself might be pleasurable to you. This suggests that anyone with an asshole has the potential to feel anal pleasure. If they can it can feel those nerve endings, they can feel some pleasure, regardless of what gender or sex gender they identify as now, or the sex assigned at birth, or sexual orientation. It's really kind of universal. Let's talk about these sphincters a little bit more. The outer sphincter is a voluntary muscle. It's like your mouth. You can't use it as, fluidly as you can your mouth, but you can control it at will. You can kind of open and close it. And you, in fact, might even kind of notice, you can squeeze that part of your body and notice you're closing it, kind of opening it, relaxing a little bit. This inner sphincter is involuntary. So you have to be able to relax to allow that to open up. And the voluntary muscle, the outer sphincter, it's part of your sympathetic nervous system. But the involuntary muscle, the internal sphincter, is part of your parasympathetic nervous system, which means that you don't control it so directly, like your heart beating. You can't do that yourself. You can speed it up by exercising a little bit, and you can breathe deeply and slow down your heart rate. And similarly, with some deep breathing, with sexual arousal, with relaxation, the internal sphincter can start to relax and open up, but you can't just will it to do that. This also is something that's important because these parts of your nervous system are related to the fight and flight response. So if you force something in here and it starts to clamp down, it's going to be communicating to your body, uh-oh, something's wrong here. Danger, danger, danger. Clamp down, try to close up. It also means that emotional care during anal play is really important because these parts of your body respond to emotion. So it doesn't necessarily mean that you have to be in love with someone in order to have anal intercourse or anal play, but you might notice, if you're an explorer yourself, that when you feel some sort of emotional connection with someone, it does ease the pathway to pleasure. And that can be for pleasure of all sorts, not just related to this part of the body, but particularly for this part of the body to relax and receive some kind of connection or arousal can be particularly conducive to that. Now, I know I'm kind of breezing through this, so hopefully we're going to have time for Q&A later. So I'm covering quite a bit at a speedy rate. Just hold your questions or throw them into the chat so we can get to them. Now, because it's also part of the involuntary, it's an involuntary muscle, this internal sphincter, it's very important that if you introduce anything into the rectum, you make sure that the base of that thing that you're introducing is bigger than the thing that you're introducing. So you notice here, there's a flared bottom here. And that's because this flared bottom is very unlikely to get past here into the body, into the rectum. If you put in something like a cucumber without a flared bottom, this involuntary muscle can start to contract and move things into the body. And then suddenly you've got an object that's kind of stuck into the rectum or starts to migrate further up. And instead, if you got a finger or a few fingers or a fist, you're not going to be able to get someone's entire body up in there. It's got enough of a base that you can safely have something in there and then also be able to remove it. All right, I've spoken quite a bit. I'm going to show you a little video now.
This is where your ice cream comes from. The creamy poop of a mystic unicorn. Totally clean, totally cool, and...
Just checking, Jim, can you all hear that? Or someone nod your head if you can hear it?
Yes, we can.
Yay! Okay, thanks.
soft serve straight from a sphincter. They're good at pooping. But you know who sucks at pooping? You do. That's because when you sit on the porcelain throne, this muscle puts a kink in the hose and stops the Ben & Jerry's from sliding out smoothly. Is that a problem? I don't know. Are hemorrhoids a problem? Because sitting at this angle can cause hemorrhoids, bloating, constipation, and a buttload of other crap. And seriously, unicorn hemorrhoids? The glitter gets everywhere. But what happens when you go from a sit to a squat? Voila! This muscle relaxes and that kink goes away faster than Pegasus laying sweet sherbet dookie. Now you...
All right, I'm not going to show you the whole video. This is for a device called the Squatty Potty, which helps you squat when pooping. But what I want to point out here is this muscle here. It's called the puborectal sling, and we're going to look at that in a little bit more in depth. And what you notice in this video is this little unicorn, which is mimicking the human body, is that when the unicorn squats, this muscle relaxes. This muscle actually is responsible for 80% of your ability to hold gas and poop inside of the body, which also means it's responsible for not allowing or allowing something inside of the body, into the body. So let's talk about that a little bit. Here's the front of the pubic bone. So the front is over here. Your belly button would be somewhere over here. Here's your tailbone. Here's the external sphincter, the internal sphincter, a little anal opening right there, anal canal. And then here is the rectum. And then over here, somewhere up here would be the sigmoid colon. What you see is that just beyond the anal canal, these two sphincters, is the puborectal sling. And that it cinches forward. It's a sling because it pulls forward. But if you're squatting, or if your body is aroused, sexually aroused, perhaps by stimulating the sensitivity of the anal opening with a tongue or a finger or an object or some lubrication, it allows this muscle to relax. And when it relaxes, then you notice that there's less of a curve in the rectum, which then can allow something to go inside very easily or more easily. So the puborectal sling is very, very important. It is also the thing that gets stimulated when poop or gas leaves the sigmoid colon and enters the rectum, and you get that sense of, oh, there's something in there. Huh, there's something in there. And then your body senses when you sit down to poop or squat, it relaxes this muscle and allows things to exit. So a couple other things here. So I'm just saying the same things here, but just to walk you through it. When gas or shit leaves the sigmoid colon over here and fills the rectum, we feel the urge to relax and release. That is the rectal reflex. The fullness in the rectum communicates to the puborectal sling or the puborectalis muscle, which then relaxes and you poop. And that muscle is responsible for 80% of your ability to hold things in. One of the things I also want to point out here is that sometimes people say, one of the common questions I hear is, okay, there's definitely like one hole I have to get through in order to get someone inside me. And that is this. They're talking about the anal canal. Actually, there's two things here. There's the external sphincter and then the internal sphincter. So sometimes people say there's two things I have to get through. And then they say, oh, there's something else too that I feel just beyond that. And that very well can be the puborectal sling that they're referring to, they're having trouble relaxing that. Also, you might notice here, if this is not relaxed and someone tries to force entry here, if they bump up against this muscle, what is that muscle's job? It is to cinch forward and keep things inside the body. If you inadvertently bump up against that muscle during anal play, you might be communicating, oh, danger, there's poop in there, I got to release, or there's gas I got to release, even if the rectum is completely empty. Sometimes that can happen for folks. Okay, keep going to this. Okay, let's talk about fiber for a moment, because the rectal reflex is dependent on a sense of fullness inside of the rectum. But I think maybe you all know this already. A lot of us don't have enough fiber in our diets. And so we may not have actually a sense of fullness inside of our rectum, because if we don't have enough fiber in our diets, or if we're on medications, or we've been living with HIV for a long time and have had some issues with our GI tract, or just another medical condition that's had issues related to GI stuff, gastrointestinal issues, what can happen is that as food is being digested and poop is migrating through here, it's not properly kind of coming together, and instead it's coming in little bits. In this case, this is someone who's constipated. It's sort of like little clumps of it. And so someone can then feel like, oh, I've got to push in order to release, rather than just relax the respond to the rectal reflex by just relaxing the puborectal sling. So I'm going to show you again another image of the puborectal sling here. You can refer to this later. It's got a little bit more detail there. Another image there. But what I want to get to, sorry, I misordered these slides a little bit. We'll get to fiber in a moment, but I wanted to show you this image also of the puborectal sling. Here's the tailbone over here. Here's the spine. Here's the front of the body. And then you can see this is the sling here. And there it is. It's just above the anal canal, and it's cinching it closed. All right, sorry. We will get back to the issue of fiber in a moment, but let's get to the clitoris first. That's important. I like that. Let's go there first. Let's talk about the clitoris and how that might be related to anal pleasure. And for this, we'll watch another video.
The body is absolutely boggles my mind. Now, I've spent a lifetime drawing the nude. And when I actually discovered the internal clitoris, I think it was in the early 90s. So this is the internal structure of the clitoris. The leg of the clitoris, it's like a wishbone. Shaft of the clitoris. Clitoral glands. The bulbs of the clitoris that go down deep in the body on either side. We have nearly as much erectile tissue as men. We get erections too when we get turned on. But because it's internal, and most of us have been so badly repressed that we don't even recognize when it's happening. And here we have vaginal opening, urinary tract opening, inside the body. This is all inside the body. There's the perineum. It's the space between for a man it's between his asshole and his balls, and for a woman it's between her asshole and her vagina, the perineal sponge. Best of all is in the little, this is 8,000 nerve endings here, so this has got a lot. You can feel your clitoris get an erection. Well, let's go on down. I don't want to leave out the asshole. I must say I'm quite fond of the little buddy hole. It's cute. Here's the PC muscle. When you tighten your PC muscle, and you can feel it in your clitoris, and in your vagina, and in your anus, then we can deal with the external. So here we would have outside. This would be pretty closed. You wouldn't see too much. And we'd have the inner lips. Hopefully nice full ones. They're my favorite. Oh, outer lips. Now you're not going to see much of the pee hole in here, and the vaginal opening will be not easy to see either. Oh, I just can't control myself. It's different in absolutely every woman. It is amazing.
And there you go. It's basically the gist of it. I wanted to make sure we talk about the clitoris and the legs of the clitoris. It's something that about 15 years ago was news to me, that there was more to the clitoris than what you could actually see. There's more of the body of the clitoris inside of the human body. And here, you can see the glands here. That's kind of what you could see of the clitoris. But look at all this other structure that's here. And what you see here, and this is an image of someone who is transmasculine, who has a clitoris and also a neopenis, neophallus. And what you can see here is if some fingers are placed inside of the rectum, you see how the legs of the clitoris, the bulb of the clitoris, extend further back into this region. So stimulation here, here's the anal canal, here's the rectum. You can see how actually you could be stimulating part of the clitoris through anal play. And this is one reason why people who have a clitoris may derive pleasure from anal stimulation, even if they're not directly stimulating their clitoris directly themselves. This is another image. This is someone, a cisgender person with a clitoris. And here in this case, it's a penis, and same principle. You can see that the clitoris extends toward the anal canal and the rectum. And then here in blue, yellow is the clitoral glands, the glands there. And then in blue, you can see how these extend further back. Some of those images came from this really great review article. I'll show it to you on our website, called Pleasurable and Problematic Receptive Anal Intercourse and Diseases of the Colon. It says diseases, but it's also really got great images that you can use, really inclusive images. Now, you also sometimes hear a question from folks. They say, when I'm bottoming, receiving a penis, for example, or a fist or some other object, it feels like I'm going to pee and then like I'm going to come, like I'm going to ejaculate or orgasm, but nothing's coming out. What is going on? Now, in someone who has a prostate, it's the prostate that they're feeling. And part of the reason there is because it's very close to the bladder. So the prostate's about the size of a walnut, not hard. It's kind of spongy and softer than a walnut. You can feel it a few inches inside the rectum, pressing toward the belly button. So it's right here. It's right next to the bladder, and the urethra passes right through it. So pressure on the prostate can put pressure on the bladder and make it feel like the bladder is full, even if the bladder is empty. So that is part of the reason where people, during anal stimulation, if they have a prostate, can feel like, oh, I feel like I'm going to pee. But I also feel pleasure. Well, the pleasure comes from pressure on the prostate. Here's another image of the prostate, and you can see the relationship between the rectum, the prostate, the urethra, bladder. You can see urine passes through the urethra, through the prostate. And rubbing, this is what I want to communicate about this in terms of pleasure. Rubbing the rectal wall about 2 inches inside, 2-3 inches inside toward the belly button, you can actually feel the prostate there. And rubbing against it can produce a sensation of orgasm or can heighten orgasm. And that is because in someone who has a prostate, the sensation of orgasm is actually the squeezing of muscles around the prostate. It's not necessarily ejaculation. It's pressure on the prostate that can give someone the sensation of pleasure. It may feel like peeing at first, like I've said. It's kind of akin to the G spot or Grafenberg spot. There's some debate about whether that spot really exists in female anatomy, which is about a few inches in the vaginal canal and toward the belly button. It's a very similar corollary to that, would be a few inches in and toward the belly button for the prostate. It is not the sole source of pleasure. The sense of fullness inside the rectum can be pleasurable. The sensation of rubbing or licking or touching the anal canal because of all those nerve endings can also be pleasurable as well. Lots of other sources of pleasure. Orgasm, as I said, results from contractions around the prostate, even without ejaculation, and these can be very distinct experiences. Someone can experience pleasure here, and in fact, someone can have a completely flaccid penis while they're experiencing intense pleasure in the rectum or anal rectal area. And sometimes people are concerned about that, but it's completely normal for someone to not have an erection during anal play. The prostate is, it's kind of like a BlackBerry, not those old phone devices, but like a actual BlackBerry. It's full of fluid, so that's what makes it kind of spongy. Another reason that people can experience pleasure is that the bulb of the penis is right here. So as you're rubbing inside here, you're also kind of like the legs of the clitoris. This is the corollary here. You can see you can be stimulating those as well internally. Okay, just more images of that. And then here's an object, sex toy that does that. And here's an example of a sex toy that makes use of stimulating the prostate by relying on some of these pelvic floor muscles, which is what we're going to talk about next. And then we will, I swear, get back to fiber. Just another image. This is one from another one of those articles I mentioned, the review article. We've already kind of talked about this for folks who are identify as trans. This is just more images. I think kind of shown these, but in this case, this is someone with the neovagina who still has a prostate and can experience pleasure that way because the prostate is still here and there can still be stimulation rectally. Let's talk about the pelvic floor muscle. These are the muscles that you see here in pink. And the main thing I want to communicate about this is that if you are enjoying anal sex without pain, and there's really zero reason to experience any pain, remember our mantra of ouch. If there's any sense of discomfort, physical or emotional, it's time to change things, to shift toward pleasure. Stop what you're doing and shift toward pleasure. If you are exercising these muscles in your body, then generally what you're doing is you're increasing the blood flow to those muscles and increasing muscle tone and control. They also can increase the intensity of your orgasm. So generally, you can strengthen these muscles both to increase your pleasure, but also to increase the health of that part of your body and health during anal sex. What I want to point out is that these muscles this is a female anatomy and male anatomy on the right-hand side. And look, these muscles are generally the same. Some of the anatomy is different. Anatomy is different between people regardless, right? In terms of shape and size and strength and all sorts of other factors. But these muscles exist in nearly every human being. And you can strengthen those muscles. You can do what are called Kegel exercises. So the very briefest version of this would be, as you're with me right now, if you would just pretend like you're about to pee, don't pee though, and then stop yourself from peeing. You notice that you're doing something, you're strengthening, you're squeezing some muscles. There's somewhere between your vaginal opening and your anus or your scrotum and your anus. You can learn to coordinate those muscles and strengthen them. Now, a couple other things before we get into the Q&A. I'm going to just mention that sometimes people like to use numbing agents for the anal canal as a way of trying to ease into anal sex. I'm going to recommend that you not do that as part of your harm reduction approach. These numbing agents deaden sensitivity to nerves, so that instead of feeling what you're feeling when you're touching your palm, you feel a little bit more of what you're feeling when you're touching the top of your hand, or maybe even touching a fingernail. There's less sensation. And remember, a sensation of ouch is an indication of potential damage. So stop doing what you're doing and shift gears. But if you deaden that sensation, you're not able to actually shift gears. So rather than block your ability to communicate, your body's ability to communicate damage, instead try some of the other techniques that I've mentioned, like deep breathing, stimulation, arousal, some other things that we can get to. Other people like to use something called poppers or amyl nitrate. This is a liquid. It comes in this bottle, but then it evaporates very quickly. And it causes blood vessels to dilate, creates a rapid drop in blood pressure, and then your heart sort of pumps really quickly to stabilize the pressure. But it means that it relaxes those anal muscles that I just showed you before. Some people say that it enhances the orgasm and reportedly relaxes muscles. But again, this is an area where no one's done a scientific study where they actually measured this. This is mostly just self-report. There's some potential side effects of using this it's not a medication, of using this drug as well. But people use it to try to engage in anal sex in a more pleasurable way. It's very common. People use it. Let's get into douching for a bit, and then we'll get into frequently asked questions, the website, and then frequently asked questions. So about 80% of gay and bisexual men douche prior to anal sex, and 10% of those men report rectal bleeding after douching. So there's something potentially harmful going on here if someone's bleeding, because there's really no reason for anyone to experience any bleeding or any pain during anal sex or douching. So this is a suggestion that providers or healthcare workers should be talking about douche safety with their clients and ways of reducing bleeding and other ways to address concerns that people have. People douche because they're concerned about contact with fecal matter during anal sex, or what they call sometimes painting. So if here's an anus here, and here's an object that's going in, if it goes in, if the object comes out, some of the people are really concerned. I don't want to leave any poop on that object, that penis or hand or finger or fist or toy. There are other ways to manage that. One is by increasing your fiber intake. In one of the workshops I did, some of the participants came up with an expression, an apple a day keeps the shits away. So that's why we have an apple up here. An apple is a source of fiber. There are other sources of fiber like Metamucil, also called psyllium, or flaxseed, or chia seeds, or just increasing the amount of natural fiber that you're eating every day. If you're committed to douching, though, the recommendation is just to use warm water and a smooth-tipped, lubricated device a few hours before sex. There really is not any great scientific evidence about how much water should you use, how often should you do it, the timing of it. We are learning more and more about that now because there's more research on this topic. So more to be revealed, hopefully. I'll show you this little video.
It works like a sponge going through your body so that when you go, you fully go. This, of course, reduces prep time and makes you more comfortable and confident.
So what you're seeing here is
it works like a sponge going through your body so that when you go, you fully go. This, of course, reduces prep time and makes you more comfortable and confident.
When you feel the rectal reflex, you're feeling fullness in the rectum, and when you release, it's all released, and there's no visible signs of poop left.
It works like a sponge going.
Okay, I'm going to skip this video, refer to it a little bit later. Some people also use condoms as a way of avoiding contact with poop, and this is an image of the female/internal condom, which was originally designed for anal sex. You can see it here in these bright pink circles. It was originally designed, this is the original flyer for investigational use of the internal condom for anal sex. People use that now as well. And there's a cool video that you can see a little bit later if you'd like to see it a little bit later. All right, let's get to the website and then make sure we've got some time for resources. For questions and answers. All right, here's this website that we developed for our project. Got lots of resources here. You'll see lots of things. All these different cards are different resources. So I'm just going to orient you to them. You can search for different topics. You can search for the format. You can search for specific populations. You can also just search in here for something. And then at the very bottom, you can select a language and it will translate the entire site to that language. So hopefully that's helpful. And then if you're a healthcare provider, you also can, here's a little webinar we did similar to this one. You can see these resources that we created. So there's some client-facing resources if you want a poster to share with clients here with some frequently asked questions and answers, and you can get access to our website. And there's stickers and other things on there too. We've got intake forms as well. So not as thorough as Sammy's SOPs, but hopefully helpful here. And we've got some other things as well. We've got this linking directly to that article that I mentioned before. It was about pleasure and problematic anal sex. and concerns there. And you can also see our selection criteria here, how we chose things, our science library, where we've tried to collect as much of the research as we possibly can. And what you can do is if there's a particular topic you're interested in, click there, and then you can see the articles here. You click on an article, and then it will pull up that article for you free of charge. Most articles are available there. You can learn about us and who we are and our advisory board and implementation partners are all here. You can see Jim is here. That's how he knew about this project too. And you can also contact us with any questions if you'd like to. Okay, that's our website. And I'm gonna skip the topic of lube for now and just make sure that we have time for Q&A. Leave you with one other thing about the microbiome, which is important, which is when engaging in anal play, if you have a vagina or a neovagina, it's always important to wipe front to back. It's the same principle as when you go to the bathroom, right? You wipe from front to back. And that is because the bacteria that live inside of the rectum and the anal canal, they like to live in the vagina too, but they can cause some problems there. So rather than give them that environment to live in, always wipe front to back. Likewise, if you have anal play, go from front to back. But if you go from anal canal, anus, rectum to the front, make sure that you use a condom or wash whatever that object is before you potentially introduce those bacteria into the vaginal canal. Okay, resources, I've talked about that. And then the last thing I'll leave you with is, this is a big team of people who've been involved in this project. Great, wonderful people who've been involved, including all these participants who've contributed to creating the resources that you've just seen. So I will stop there. Hopefully then we've got at least a little bit more time for Q&A.
Wow, Brian. Thank you, thank you, thank you. Please give him some love with your emojis in the chat, what have you. We have a number of questions that have come in the chat, which we'll get started with. But I'll also remind people we'd love to hear and see you. So if you want to ask a question on camera, on video, please raise your hand. But while we're waiting to do that, we have one that just came in from Evie, but I'm going to go back up a little bit. Earlier in the presentation, and we had a couple. So let's get through those quickly. The first was from Sam, and he says this: you mentioned that men over 50 that you spoke to asked if it was common to bleed during anal sex. And I'm wondering if you could talk about how the mechanisms of anal pleasure change as you age and what folks can do to maintain pleasure.
That's a great question. Okay.
It is.
So, yeah, great question. Okay. So one of the things, this is actually related to Sammy's talk. Sammy showed you some of those images of HPV, and HPV doesn't always manifest as explicitly as that. And in fact, there's potential as we have sex. If you've had sex with anyone and you don't have the Gardasil the vaccine, even if you do, potentially you don't have protection against all manifestations, all strains of HPV, which means you can acquire warts in the anal canal or in the rectum as well. And if that happens, then you've got a little bump in there that then can cause friction. If you don't have enough lubrication, even if you do have enough lubrication, it can cause friction and then cause some bleeding. It's also possible as we age, we sometimes accrue hemorrhoids, which is like a varicose vein that's inside the anal canal or inside of the rectum. And rubbing up against that also can cause some bleeding. The reason that we generally have hemorrhoids, partly it's age, but part of it is that we just sit all the time, most of us, and also we don't have enough fiber in our diets. So those are some reasons why there might be bleeding. There could be other ones that I haven't thought of. Also, people who've been pregnant and had a baby increases the likelihood of developing hemorrhoids as well. So there's lots of different reasons that could be happening. The take-home message is, if it's happening, find a provider to help you get it checked out to make sure you can stop it from happening, if possible.
Thanks, Brian. And then a little while later in your presentation, someone noted that someone at their agency had informed them that trans masculine folks can grow prostate cells through hormone therapy. Have you heard about this? And he was actually curious if it's true or
Yeah, I don't think that that is true. I've never seen any evidence that that would be true, and I can't imagine how it could possibly happen. What can happen for transmasculine folks who are on hormones is that the clitoris can become enlarged or get larger, and that can then it can start to feel like a little bit like they've got a penis there too. But it also, if the glans is visibly increasing in size, I could imagine that the bulb of the clitoris is also increasing in size, which potentially means that anal stimulation could be a little bit more pleasurable because there's more contact with the legs of the clitoris, kind of like the prostate would be, or the bulb of the penis would be. Great question. I've never had anyone ask that.
Yeah, that was the first time I've seen that too. So thank you very much for sharing it.
Yeah.
And just recently in the chat, I'll read this from Evie or Evie. Douching can also cause irregularities in intestinal microbiome. From the information you gave us, it is pretty obvious that with a good diet and hygiene, you really have nothing to be afraid of. Is there any way we can advise someone that still feels afraid and wants to keep douching so that they can make their douching more microbiome friendly? And before you actually answer, I would just also want to emphasize that douching is extremely normalized. Like people all over the world douche. It's a very, very common behavior. And I think that's why the HIV prevention field has kind of glommed onto it to see if they can create a safe douche that can also prevent HIV, to sort of harness a behavior that's already very well established. But we definitely know that there are healthier ways to douche and there are ways to douche that are not so great for your microbiome. So with that sort of setup, I'll let you take it from there, Brian.
Okay, great. So this is like the pipeline is starting to produce more scientific knowledge on this, and Jim, you're pointing to that, and you've also been a very early advocate. My first knowledge set about this came actually from the work that you did with International Rectal Microbicide Advocates. So that was an incredible experience to learn from you and that group. So over-the-counter douches. Actually, let me back up a second. I grew up in the 80s, and there was something called Summer's Eve that was advertised on television, which was a vaginal douche. I never see any vaginal douche advertising anymore because we have grown to realize you do not need to clean out the vagina in order to have sex. And similarly, you do not have to clean out the rectum in order to have anal sex. You can either accept that there might be some little microscopic bits of fecal matter, or that encountering fecal matter at some point is normal and acceptable for some people. But if you're going to douche, as someone, Jim put it in here, shit happens. Yes, that's what happens. As one of my participants said, if you're digging for gold, sometimes you're going to find a little bit of, or if you're digging for diamonds, every once in a while you're going to encounter a little bit of coal. That's what they said. So we can normalize it. It's just part of the body. It doesn't mean that you have to be so embarrassed by it if it happens. Over-the-counter douches some of them tend to be higher in sugars and salts. And so if you introduce them into the rectum, they can, through osmosis, kind of deplete some of those cells and then cause a little bit of cellular damage, which then can be a problem. But also, as you're washing out the anal canal or going even further up going past the rectum into the sigmoid colon in what might some people call a colonic, going past that point, you also can be washing out some of the good bacteria that are there. I have not seen terrific evidence about this topic. So what I'm sharing with you is the best that I know from what I've learned from the science that exists, and also the community knowledge that we've developed over our thousands of years of having anal sex and the last 30 to 50 years of people being willing to talk about it a little bit more openly. But I don't have great information to share with you other than if you're going to do it, if you buy an over-the-counter douche, empty it out, fill it with just body temperature water and introduce that. Make sure that the tip is lubricated so you're not damaging anything as you're going in. Hold it in the body for a little bit and then evacuate.
Yeah, and I know sometimes we've advised people you might want to put I mean for the chefs amongst us, put a little
Mm.
pinch of salt in there to sort of mimic the salt content in your body. Not too much salt, but just a pinch to make it a little bit of alkaline. We have a question from Evie, who's not able to ask it on camera because you're in clinic, but I think this is where she's going. So some people after anal sex have, may have diarrhea or constipation. Are there ways that some of those after effects could be minimized?
Um, so there are a couple of things there. So some of it could be related to diet, and we have a resource on our website called it's called the Bottoms Digest. And so it's meant to be um, food that is conducive to anal play and regularity. So that could be some of it. Um, some of it also could be that the muscles are just relaxing more. I don't buy that argument. I think it's probably more likely it has to do with diet and fiber intake. And one of the benefits of using a fiber supplement, like something like chia seeds or flax seeds, or just adding something like Metamucil or which is psyllium husk into your diet, is if you add it to your diet, then you have regular bowel movements in the sense of not only that they are full and the rectal reflex is stimulated and you evacuate as fully as possible, but also regular in the sense of the timing. So you take your fiber in the morning and the afternoon, if you do it that way, you'll notice that your bowel movements happen generally around the same time, regardless of whatever it is that you're eating, which means that you can also time your sex accordingly. So that would be my recommendation for that. But I've not seen great information that I could say answers that question directly. I don't know if anyone else has. If you have, please put it in the chat.
Yeah, and I'll take that moment to say, we would still love to have someone join us on camera. Raise your hand if you want to ask a question or make a comment. We are in our final minutes, but we have time to see somebody. So if you want to, don't be afraid. And don't be shy. But in the meantime, we do have something in the chat from NZMZ. And so he's saying, or they're saying, during deeper anal play, there's often the experience of hitting a wall. I think you kind of got into this a little bit, Brian. Do you have an explanation for what this is and how to get past it? And a potentially
Yeah.
related question would be, how can you safely straighten out the sigmoid for deeper play?
Okay, I'm going to share my slides again and go backwards.
Perfect. Thank you.
Okay, so this is the one that I wanted to point out. Okay, so okay, so the question was, I'm sorry, wait, Jim, tell me the question. I just forgot it.
Yeah, no problem. So they're just saying, sometimes you have this experience of hitting the wall. Is there an
Yes.
explanation? How do you get past it? And is there a way to sort of safely straighten out that area
Yeah.
for deeper play?
Okay, great. Okay, so the wall could be the internal sphincter tightening during anal play. If someone starts to feel uncomfortable or fear or anxiety, can also tighten that. It also could be the puborectal sling, which is here, right? That muscle beyond those sphincters. And the way to relax that muscle, there's two things that you can do, or three things probably. One is when you're going to the bathroom just regularly, respond to the rectal reflex by actually just relaxing. Don't push, because the more that you push, you're communicating that you have to push beyond the natural relaxation of the puborectalis, the puborectal sling, just naturally relaxing. So instead, squat on the toilet and then just see if you can just relax. To help with that, fiber can help you learn or relearn your rectal reflex, because as poop enters here, if it's little bits of poop, you might have a sense of like, oh, there's something in there, but then you sit down and there's nothing coming out. But if you properly bulk your poop with fiber, when something enters here, you more reliably can be like, oh, I can tell what's going on in my body. And then I go to the bathroom and it relaxes. Those are not about anal play, but they're about understanding your body and responding to your rectal reflex so that then you can feel what it's like when this muscle relaxes. And then the other thing to stimulate that would be stimulation of the anal canal with a tongue, an object, lubrication, a finger. That kind of arousal can also allow that to open up and relax. If there's a sense of fear or anxiety, this muscle will contract. So you want to do the counter to that. And then the last thing I'll say here is sometimes there's what people refer to as the third wall is actually an object going beyond the rectum and into the sigmoid colon. And you notice that curve there feels like you could be hitting a wall here if you're going beyond that. For example, if you're fisting, you can feel like that's happening.
Thanks, Brian. While you have your slides, as you got rid of them,
Yeah.
oh, excuse me. Someone had said if you wouldn't mind just kind of quickly like clipping through what you have in terms of your lube slides. I think there's obviously always people want to know more about lube, and there's a lot of misconceptions about it. So if you could kind of go over these quickly, and then we will get ready to wrap up since we are at time. Thank you.
Sure. All right, so let's talk about lube a little bit. Okay, there's three kinds of lube, three categories. There's oil-based lube, water-based lube, and silicone-based lube. And this is I'm referring back to Jim's early days with Irma. There was a great handout here that was about lubricants. And the message here is that the rectal mucosa, it's just one cell thick. It's not very well lubricated. There's a little bit of lubrication in there. And if you don't introduce lube, it easily tears when objects are inserted inside it. Douching also removes the natural lubrication and also can kind of compromise the integrity of the rectal lining, like we mentioned before. So with these three different kinds of lube, water-based lube, it's safe for latex condoms and silicone anal toys, but it's also absorbed really quickly into the body. So you have to keep adding to it or adding some spit or water lubricant to it in order to kind of revive it. Silicone lube, safe for condoms, latex condoms as well, but it's not safe for silicone anal toys because if you introduce silicone onto silicone, it will start to erode the toy. But it lasts much longer. Silicone's actually little tiny beads that rub up against one another, and they don't get absorbed by the body, so it lasts longer. It also sometimes can stay in sheets, so sometimes people want to put down a towel for that. And then oil-based lubes, they last a long time. They're not safe for latex condoms. They are safe for polyurethane condoms, like the internal condom, but they also tend to gather bacteria on anal toys and fingers, penises, whatever else is introduced. Even though they last longer, the recommendation is not to use those inside of the rectum unless it's something that's a little bit more antibacterial, like coconut or almond oil. Those could be used if you're dedicated to using lubricants that are oils. All right, that's the quick down and dirty.
Fantastic. And remind us, you can find a lot more about lubricants on the Anal Pleasure and Health website, correct?
Yes.
So Caesar, you said you want to ask a question. Do you want to come off camera or come on camera and ask your question?
Yes.
You are still in the house. Go ahead, ask your question.
Thank you. Thank you so much for the opportunity. Thank you also for the information. For me, as a Spanish speaker, it's like a gold mine to find all these resources about this part of the health and especially LGBT population. But talking about that, it's just curiosity, I would say, that how is the process, or I'm more curious about how is the process or how is the body inside when this situations with fisting of big objects are happening, because sometimes through the porn sites or just like in sexual events, you can see like a lot of movement, a lot of the size of the hand is like, or the whole hand is going in there. And sometimes I think like, what are the intestines? Where are that hand is going? Because it's like a lot. Like, is they're removing the whole organs? Is there some damage? Like, how could be that the scenarios? Thank you.
It's a great question. Okay, let me share my slides one more time here.
Yes.
Okay. And what I'm going to point out here, I'm going to go back to that other image that I had of the sphinx. Here we go. Okay. So what you're going to notice here is here's the anal canal, here's the rectum, here's the sigmoid colon. If a fist goes in here, it's got to get past the anal canal and into the rectum. And this is about a couple inches here. This is 5 to 9 inches. So you could fit, maybe it's hard to see here, but you can fit about that much up to the middle of my wrist inside before you get to the sigmoid colon. If you go beyond that, you start to go into the sigmoid colon. But even then, you're not coming in contact with organs. You're inside of this canal structure. So you're not actually touching organs. It's sort of enveloped inside of these structures here. And an anal rectal surgeon will tell you under general anesthesia, if they need to operate on this part of the body, this part of the body can expand pretty easily so that you can actually fit things inside the body and do operations. So with proper relaxation, people can relax that part of the body without the potential for damage. There may be damage if someone is experiencing pain or discomfort and just sort of forcing themselves through that. And as you pointed out in pornography, what you see is, well, you didn't point this out, but I think generally let's accept that what you see in pornography is not the entirety of what goes into actual preparation for fisting. There is lots of preparation, lots of addition of lubrication, lots of stimulation. There may even be some substance use, some psychopharmacological, additive like poppers or something else that people use in order to relax enough to participate in that. You don't have to, but people sometimes do. So what you see in porn is often the myth of what's actually happening. What's actually happening is a little bit more. There's like a pre-porn video that should be out there about how to do this. I've not encountered a great video on how to do fisting yet, or a great resource yet. If anyone has one, please send it to me so we can put it on our website.
Yeah, and for me, it's like kind of interesting, some videos when you can see the hand of the one person like moving on the belly of the other person, and I'm like, is that safe? I mean, I'm concerned. I'm not scared because it's sex. We know we have been like willing with that, but in those kind of situations, for me, it's like I hope that the guy is fine.
Yeah, you've naturally got some concerns about that. That makes sense. Again, have I seen a scientific study that's actually examined this? No, I haven't. Part of the reason is we don't get enough research on this topic. So I can't speak to it scientifically, but in general, every physician I've spoken to says if you're experiencing pleasure, not tolerating pain and discomfort, in general, you're introducing some healthy blood flow to parts of the body that ordinarily might not get it. I can't speak to the seeing a fist through, visually in that way. Can't speak to that one though.
I think people have advanced in practice to get to that stage of, I'm in the clinical space right now, but in their personal lives. So their body has acclimated and they have learned the curves of their own body to be able to handle that visualization.
Mm-hmm. Yes. Well said, Christopher. Thank you for adding that.
Thank you, Cesar and Christopher and Brian. Really wonderful talk. Before we wrap up, I dropped in the link to your survey for the next grant proposal you're working on.
Yes.
Do you want to just give a little bit of color commentary for that before we finally close out this webinar?
Yes. So we are preparing a grant proposal to try to do something akin to what Sammy is doing. We want to do that a little bit more in the United States. We have some data from the study that we've done looking at the workshop. We want to kind of look at this a little bit more. And in order to do that, we'd love your feedback about what you learned today. So if you could fill out this very brief survey, it'll just take you about 3 minutes to do that. It would help us learn what you got from this and your interest in the future of this kind of research. It'd be very, very helpful if you could do that.
Thank you. And so let's give everyone a virtual, or give Brian and Sammy a virtual round of applause. Thank you so much, both of you, for sharing your expertise and really, really great information. Brian, I feel like we need to have you come back every year because this is just something that needs to penetrate, so to speak, our field much more. And we need to normalize how we talk about anal health and anal pleasure. I think anal and pleasure often do not come up in our field, and it's often pathologized, and we need to really flip the script on that. So I want to, again, thank you so much, both of you, for sharing your time and expertise. Thank you to everyone who came and joined us live today, to the almost 350 people who registered for this and will be consuming this webinar on their own time. We will be sending out an email when our resources are posted online. So the slides will be posted, this recording will be posted, and a resource document with some of the links that we shared will be there as well. I hope to see you at our next webinar focusing on transgender women and being more, and their needs being much greater and much more diverse in HIV prevention. That's in a week, and that webinar will have Spanish and Portuguese translation. So hope to see you then. Hope everyone's taking good care of themselves, and wherever you are, whatever part of the world you are in, have a great rest of your day, evening, or in some cases, it's already tomorrow where you are. So enjoy that, and thanks again. We're officially closing out the webinar now. Take care.
Take care, everyone.